Hello, this week, as discussed, we'll be covering Chapter 3 involving regulatory compliance. So some of the things you should get from this chapter involve the importance of an insurance carrier audit. These are increasingly becoming more common. Private insurance companies do this. Medicare, field audits, Medi-Cal, Medicaid. They all do their audits. Think of the insurance carriers. Sometimes we think of private versus government. It's important that you have the same kind of mindset for all these different types of audits. We'll get into the comprehensive error rate testing program, the CERT. We'll talk about something that's fairly new in terms of health information, the recovery audits. And then we'll talk about corporate integrity and how to audit under a corporate integrity agreement. And again, starting in 1965 with the advent of Medicare, used to be people just had to fill out the forms. Medical practices could have things all over the place, coding, very kind of slipshod, and the government just paid the bill. Now, of course, due to constant budget tightening, fraud, abuse regulations, federal and state regulations, medical offices are increasingly under the microscope. Procedure and diagnosis coding is not just used to talk about data integrity, but also medical necessity. In other words, just because you have a service coded and billed correctly, was it medically necessary? Providers need to be cognizant of coding and billing requirements for all insurance carriers, right? And these payers, including CMS, are coming back with new ways to recoup losses and get back what they deem to be overpayment. A lot of things now that people do, including CMS, as we saw in the Redding case, is they will keep data banks and look at the frequency of level 5 visits, surgeries, bypass surgeries per 100,000, and so on. And then when you have outliers, that triggers audit flags. External audits, when we talk about these, are things that are done from outside the practice. These are performed by the insurance or the government payer. And it's not that we get requests for medical record audits from a payer. It's more these days a matter of when. For electronic health records, it's a lot more easier to audit. Some things that are red flags are using the same procedure code consistently high level of E&M services, diagnostic procedures done in the office as routine, and unbundling. In other words, taking a service that's normally inclusive and breaking it down into separate lower procedures so you could get ultimately higher reimbursement, parsing them out separately as opposed to combining them as they should have been. Here are some of the more common categories of healthcare fraud, according to the National Healthcare Anti-Fraud Association. Billing for services that never happened, billing for more expensive services than were actually provided, as you'll see in the forum this week. Performing medically unnecessary services, misrepresenting non-covered services as medically necessary, falsifying a diagnosis to justify tests. We'll see a few of these later in the course, unbundling services, and many, many others. Other things that can trigger external audits, any inconsistent coding amongst partners within a group. In other words, you have a group practice, one surgeon's doing inconsistent coding from without, higher levels of E&M service for a new patient. In other words, all my new patients are suddenly more complicated and at a higher level, or always ordering a consult for every new patient, right? Unbundling, as mentioned, the modifiers, which we'll talk a little bit about. And other things would be patient and provider complaints. You have the right to complain about medical bills you think are incorrect, and sometimes these will trigger additional audits as well. Despite health information management and other organizations educating people in healthcare about fraud and abuse, we continue to see record numbers of fraud cases. 2013 alone, we've had 377 federal healthcare fraud cases. And very easy to find these. They're on the OIG website, Office of Civil Rights, and many, many others. So how do we handle an audit? Usually the best way to do this, and this is in your text, is to assign a point person. In other words, one person who is the point of contact between the practice and the carrier who's requesting the audit. You want to get somebody who's the point person who can make sure all the requests are processed appropriately and is compliant. That means they need to be the content matter expert about coding and billing practices. They must be able to have good interpersonal, particularly writing skills, be clear, articulate, and the staff need to understand the timeframes that they have to produce records, bills, and other requested materials. This gets into the RAC audits, the recovery audit contractors. Basically, these audits are done to recover money that was overpaid to providers. This involves retrospective payment and chart reviews. So in other words, we're looking backwards at claims that have already been submitted. And if an overpayment is uncovered, the medical practice or the hospital will be asked to refund payment, and in some cases, they'll take it back out of future payments. This may involve focused medical review. So in other words, say, for example, a practice had issues with infusions, not coding them correctly. They'll do an in-depth look at that practice's use of the infusion suite. So in other words, we're looking at a particular area. It could be high volumes of services. This could be use of coding, misuse of modifiers. Modifier 25 was one that was targeted for a while. And of course, your text talks about modifier. This is a famous term, the modifier of last resort from the Office of the Inspector General, known as the OIG. This modifier is often misused, and it's used to basically unbundle procedures. So in other words, you have multiple procedures, and instead of using a single comprehensive code to submit on the bill, we unbundle them and parse them out so we can bring in more reimbursement. These government audit programs look at over 1.2 billion claims each year. The Medicare contractors process the claims, make payments to the healthcare providers, and educate providers on how to accurately submit claims. We talked a little bit about the RAC audits. Some of the other things that are involved with government audits include the CERT, which we mentioned briefly, the Medicaid Integrity Program, or the MIC, and the Zone Program Integrity. And we'll get into a little bit of these shortly. First, regarding the CERT audits, the goal is to basically make sure that the claims are paid appropriately. It uses samples that are randomly generated. They request medical records to support the claim, and then they review the claim and the documentation to make sure that it's it is compliantly coded, billed, and submitted. The error rates are calculated, and then the reports on these are published. CERT will send providers overpayment letters and notices that you would be wise to pay attention to. It reports a claims error rate, how much money was paid, all this, and it's a percentage. So here's an example. For inpatient hospitals, there was an improper payment rate of 8%, and the amount estimated to be $9.4 billion. Durable medical equipment, 58.2%, improper payment, 5.7 billion. Physician, lab, ambulance, 10%, 10.5%, 9.5 billion. So you can see these kind of run the gamut. Note that hospitals, non-inpatient hospital facilities have 8.2% improper payment rate, which comes to $11.4 billion. So overall, if we looked at all these things from the CERT, 10% of all claims, $36 billion. Some of the more common CERT errors: incorrect coding for E&M, insufficient documentation, lacking physician authentication, in other words, signatures, and other things, different codes being billed, services being performed by somebody other than the billing provider, billed service was unbundled, and many other things. And we'll be talking about some of these throughout the course. Particularly, we have a whole chapter devoted to E&M. And that's all I have for you. Come back for the next lecture. We'll be talking more about recovery audits. We'll see you then.